Okay, Mr. Chairman and Joe, thank you very much for this invitation. I'm very proud to speak with such many liver surgeons, famous liver surgeons. I try to give you some tricks because, unfortunately, I'm one of the pioneers, and that means I have a lot of complications. When you begin, you have complications. So I can give you some trick to avoid them and to tell you where we are today. So today, for me, and it's not a mystery, I think indication and use of laparoscopy for liver is mainly interesting for posterior. Anterior lesion, you can treat it by small incision. Posterior lesion, it's impossible. I think it's like other part of the abdomen for rectum, adrenal glands, spleen. It's a main advantage of laparoscopy is deep and posterior, not anterior, even for colon. I'm not sure it's such interesting, even if I do it. Anyway, when you want to do laparoscopic liver resection, if you want to do it by laparoscopy, you see in my team, we have done 275 by exclusively laparoscopy. I don't speak about hand-assisted or other technique, hybrid. This is exclusively laparoscopic. And you see that we arrive for the last 100 patients to 88% of liver resection. But it's true that we don't have very, very advanced patient with tumor involving the vena cava. I mean, you will see one case, but a small invasion and so on. So we don't do a big tumor, especially, I mean, at the venous position. We do lap major hepatectomy in 83 cases. And if you look about the recent series, more than 200 cases in Chicago, Louisville, and our not published series, you see that the conversion rate is not is very different according to use not. If you include the unconversion or not the end-assisted, we consider end-assisted like a conversion. Today we can change, but I think it's a good idea to change maybe. But anyway, this is 6%. My concern is about indication of surgery. You know, as I said by Daniel Cherki, that in France at least, we think that benign lesion is very rare indication. And we don't see so many in France. But I see that in the US, maybe they change indication, maybe not. Maybe it's a position because in Chicago, when you compare laparoscopy and open, it's almost the same figure, or quite similar. And we try to keep the same indication. I'm not sure we are right. But until now, until we have no proof of the benefit, we try to not modify the indication. And the other question is, do we change major resection for posterior lesion? I think the response is mainly yes. And if you look at this very nice paper of Shaw, we specially test the anterolateral segment against the posterior segment. And as you see, the conversion is double. The operative time is much more. And the transfusion is also much more, twice. So hospital stay not difference, morbidity not such, and mortality no difference. But if you look about the technique used, you see clearly a big difference. For posterior lesions, they use mainly major resection, and for anterior lesion, mainly minor resection. So I think we understand, everybody understands that. It's easy for posterior, if you do a major, you don't care if it's posterior or anterior because you cut on the other axis. So I think it could be an answer. The second question is to see about the cause of conversion or hand-assisted. And you see we have very few localization as conversion or hand-assisted. And it was before 2003. So posterior localization, unclear number of mets, limit of the tumor. And now recently it's just finished and we have hemorrhage at conversion and some spatial situation, but not really concerned by the position or the size of the tumor. For example, it is said that some tumor is not done for laparoscopy. Maybe yes, maybe not. In our case, this patient has 3, as you see here, he has 3 mets, and we have to preserve this and do an extended right. We make an embolization, and after we do by laparoscopy a right hepatectomy.